Hello, and welcome to Module 7, Wound Etiologies, Arterial Ulcers. Our objectives today are to discuss the pathophysiology of arterial ulcers, define the components of a complete patient assessment, detail the treatment protocol for arterial ulcers, and detail arterial ulcer prevention strategies. Let's first discuss arterial ulcer pathophysiology. Arterial sclerosis will contribute to the development of peripheral arterial disease, or PAD. Screening for PAD should occur in patients with ABIs of less than 0.9. PAD can cause a reduction in blood flow to the lower extremities, which leads to tissue necrosis, ischemic leg ulcers, and acute limb ischemia. This occurs due to a sudden decrease in blood flow to a limb, resulting in a potential threat to the viability of the extremity. Always remember the 6 Ps: pain, pallor, paralysis, pulse deficit, paresthesia, and poikilothermia. Critical limb ischemia, otherwise known as CLI, is a chronic condition resulting from advanced PAD, causing significant reduction in blood flow to one or both of the lower extremities. If suspected, contact vascular medicine for a consult urgently. The most common clinical features of CLI are ischemic rest pain, severe pain in the legs and feet with ambulation, absent or diminished pulses in the legs or feet, non-healing ulcers on the legs or feet, dry gangrene of the legs or feet, and shiny, smooth, dry skin on the legs or feet. Mixed etiology ulcers, those having arterial and venous components, include signs and symptoms of both of these diseases. ABIs can determine if arterial compromise is present, and these tests must be performed prior to considering any and all compression therapy. An ankle brachial index for mixed arterial venous ulcers is usually between 0.51 and 0.90. Let's discuss risk factors. Risk factors for developing arterial ulcers include age equal or greater to 70, age between 50 to 69 years with a history of smoking or diabetes, age between 40 and 49 with diabetes and at least one other risk factor for atherosclerosis, leg symptoms suggestive of claudication with exertion or ischemic rest pain, an abnormal lower extremity pulse exam, and known atherosclerosis at other sites, including coronary, carotid, and renal artery disease. Other risk factors include male gender, Black ethnicity, family history, smoking, hypertension, and hyperlipidemia. Let's discuss the location and appearance of arterial ulcers. Typically, we find arterial ulcers between toes, present on the tips of the toes, over phalangeal heads, around the area of the lateral malleolus, and in sites subjected to trauma or rubbing of footwear. Also, we could see them in the mid-tibial region. The appearance is usually a punched out shape with even wound margins that are oval or round. The base of the wound is typically deep, pale, with necrotic tissue and very little granulation tissue. The surrounding tissue or periwound tissue is usually blanched, purpuric, thin, shiny, dry, and hairless. Let's discuss the treatment protocol for arterial ulcers. Diagnostic testing should include ABI and TBI, fluorescence imaging, oxygen assessment images if available, cultures if clinical signs and symptoms of infection are present, and the mini nutritional assessment. The primary goal of the treatment for arterial ulcers is to increase circulation to the area, either surgically or medically. As for non-surgical measures, modifying contributing factors can slow or even stop the progression of local ischemia. Treatment of ischemic wounds differ in that the wound environment should be as dry as possible. This will help to decrease the risk of infection. Remove devitalized tissue and bioburden with appropriate methods of debridement only after revascularization or tissue perfusion has been optimized. Treat infection based on the molecular image or clinical signs and symptoms of infection. If the wound is covered with a dry, hard, stable eschar and there is no signs and symptoms of infection, keep the wound dry. Paint the wound with povidone iodine, a thin layer, cover with a dry dressing, and consult vascular. Consider offloading the area if the wound is in a region where pressure is present. If the wound is moist or boggy, cleanse the wound with saline. If perfusion has been reestablished, consider debridement by appropriate means. If perfusion has not been reestablished, obtain a vascular consult. Monitor the area for signs of infection and choose the appropriate wound dressing based on exudate level per the protocol product picker. If the wound surface has not reduced by 40% in the first 4 weeks of care after adequate perfusion has been established, advanced therapy is indicated. Prescribed topical oxygen therapy using NATROX oxygen. Patient should continue to return to the clinic weekly for evaluation. Reassess the patient weekly for changes in medical history, medications, physical examination, and nutritional status. And what does the wound trajectory look like? Make treatment modifications based on this information. Wounds not moving into a healing trajectory after 3 months of appropriate treatment should be biopsied. Here's an overview of the arterial wound treatment algorithm. Patient presents with an arterial wound, obtain all the appropriate screening tests, optimize perfusion or refer to vascular surgery for evaluation. If there are clinical signs and symptoms of infection, determine if they're localized or spreading. Localized infection do not need systemic antibiotics unless the patient is compromised. Topical antimicrobial therapy would be important for this patient, and choosing the appropriate dressing based on the protocol product picker and the exudate level and quality would be indicated. If there is spreading infection, the need for systemic antibiotics is indicated based on culture findings. Additionally, choose the appropriate secondary dressing based on the exudate quality and exudate level based on the protocol product picker. Is the wound dry and covered with stable eschar? Then paint the area with povidone iodine. The wound is not dry and perfusion has been reestablished, debridement would be indicated, either autolytic or sharp debridement based on clinical assessment. Secondary dressings should be chosen off the protocol product picker based on wound exudate quality and level. Review the progress every 4 weeks. If the wound becomes static and decreases less than 40% over that period of time, consider beginning NATROX topical oxygen therapy only if no eschar is present and perfusion has been reestablished. Continue to monitor the patient weekly. Let's discuss prevention strategies for arterial ulcers. It is important for patients to have daily skin checks, wear properly fitting shoes and socks, avoid activities that constrict blood vessels, avoid use of nicotine and caffeine, avoid temperature extremes, avoid chemical and mechanical injury, and always use pressure redistributing and offloading devices appropriately and support good nutrition. In summary, poor blood circulation is the primary cause of arterial ulcers. When there is reduced blood flow, skin and tissue in the affected area are deprived of oxygen and necessary nutrients. These affected areas become inflamed and tissue necrosis occurs. Though ulcers can form anywhere on the body, arterial ulcers are more commonly found in the legs and in the feet. The hallmark of effective treatment of arterial ulcers is reestablishing blood flow and preventing infection. Here are some additional references. And this concludes Module 7. To complete the test, please click on the red test icon at the bottom of your screen with a clipboard and pencil on it to receive your certificate of completion for this module. Thank you.